So my name is Andrea Alimonti. I'm a full professor of oncology at USI in Lugano and at ATH in Zurich.
You've been looking at ADT in the context of prostate cancer, but of course in the context, and specifically in Italy, where you've just gone through a very tough time with COVID-19. Can you tell me what you were trying to do with the study that you've just now published?
My team and I were really intrigued about a recent publication on Cell a few months ago that showed that an enzyme which is called TMPRSS2 is involved in the SARS-CoV-2 infection. And why we were intrigued about this paper is because TMPRSS2 is an enzyme which is frequently overexpressed in prostate cancer. It's involved in a translocation with the ERG. And since we are like a team that work on prostate cancer, we know from many years that androgen deprivation therapy can decrease the level of TMPRSS2 almost to zero.
So what did you do in the study then to look at your hypothesis?
So we went to look into a large population of patients, and I'm at the moment in Switzerland, but I'm Italian. And we asked help to the Italian, particularly in the north part of Italy. You may be aware that this infection was devastating, in particular in a region, which is a beautiful region, it's called Veneto. You know Venice or Verona. So this region has been really strongly affected by the virus. So we have access to all the data of the region of Veneto. And we ran our study on 9,700 SARS-CoV-2 infected patients, right? And between these, we found roughly 700 cancer patients that were also infected by SARS-CoV-2. Between these, we stratify the different cancer patients according to the disease. So we noticed that roughly 30% of the population of this cancer population was affected by prostate cancer. And we went even deeply in trying to understand who's between these patients had received an androgen deprivation therapy. So the good news in terms of our hypothesis, when we found, by looking at this population, that prostate cancer patients have an increased risk to develop a severe syndrome in agreement with other data, but the one that do ADT have a lower risk to develop infection, and if they develop infection, they develop less aggressive type of infection.
Now, could you run the numbers through me, please? Because this was, in fact, a significant finding. The confidence intervals indicate that you have a definite effect or a definite association, don't they?
Yeah, so the association is like a cancer patient in general male cancer patient have 4 times more the risk to develop SARS-CoV-2. And this is go back to almost to zero when compared to prostate cancer patient in ADT. So it's 4 times less.
What are the clinical implications for cancer doctors and for the medical community generally in your findings, do you think?
I think this study is important because add an additional piece to this puzzle that try to establish a link between androgen and a SARS-CoV infection. Why this is important? Because it's the first time that we report that patients that are deprived by androgen, in this case with the ADT, have a decreased risk. Now, this can tell us, of course, this was a retrospective study, right? That we can think about to move to the clinic this hypothesis and to try to validate whether also in non-cancer patients, so in patients male patients which have been infected by the virus, a short-term treatment with androgen deprivation therapy, either first or second generation, can be effective in reducing the risk to develop a severe infection.
Now, let me get that straight. Did you say non-cancer patients?
Exactly. So the thing will be extremely provocative. So the idea would be to for instance, look into male patient just infected with the virus and that, for instance, have a comorbidity, cardiovascular disorder or other type of disorder, which bring them to have a high or an increased risk of hospitalization or to be admitted in ICU or even to die. This patient could be treated transiently with androgen deprivation therapy, and say transiently because the disorders, it's kind of fast, right? So everything happening within 1 month from the infection. And we think this could be a valid approach to cure this patient.
Now, it seems to me that by looking at the hormonal axis of the disease, COVID-19, that you're looking in a similar territory to the finding of the gender disparity and the severity of the disease. Just as many women as men get COVID-19, but men get it much worse. Are you looking at the same thing by using ADT? Because is this the male-female divide again, do you think?
It's a very good point. As you pointed out, actually, it's very clear also from our study. We have a higher prevalence actually of infection in female where compared to male in Veneto, but the infection in female were not severe. So the rate of hospitalization for the female population was really minor where compared to the one of male, and also the complication and also the rate of death. So we think that by lowering the level of androgen, we can reduce this risk and bring it to the level of the female. And this will be a significant advantage if you think about this in a large scale.
Where do you think this particular therapeutic approach lies in the spectrum of possible medications for COVID-19, medications that already exist that might have an effect or a benefit?
This is difficult to say, right? We are trying to design a clinical trial at the moment that will definitely answer to validate this hypothesis. And so we thought about, these are just a speculation, two different population of patients. So one population of patient could be, and here by an ethical point of view could be more complicated, could be a population that have a high risk, for instance, doctors, nurse, not nurse, doctor, nurse, that have a high risk to develop, to be in contact with patient, so that can be infected, and this could be somehow the prophylactic, right, type of treatment. However, ethically, this is kind of complicated because you have to decrease the level of this androgen for kind of a while. On the contrary, what we believe, we are writing a protocol in this term, is that the patients that are infected, which have an age between 70 to 80, plus a comorbidity. So for this patient, we know that the clinical outcome will be very severe. So from the moment of infection, we would like to treat this patient with transient androgen deprivation therapy, and the outcome of the study will be to see whether or not they are admitted to ICU or if they die. There is another way also to design the study that could look into the seroconversion of this patient, of time to the seroconversion. So we would like to, of course, implement also some kind of translational study where we look into the negativization of the viral load in this patient, or potentially into negativization.
So what words would you say, practical words in terms of clinical implications, would you give to doctors right now? I mean, how might they consider changing their practice, whether this is cancer doctors with patients who have prostate cancer, or indeed other medical people treating all patients with COVID-19?
I think we cannot change at the moment the standard of care for this patient. We need to do a clinical trial. And that at the moment, there are many prostate cancer patients, for instance, that are delaying their therapy because they don't have access to the hospital. And for this patient, there is an indication for androgen deprivation therapy. So I strongly recommend that these people will start immediately androgen deprivation therapy because, of course, there is an indication for that, plus they could be protected, right? So I would recommend to doctor to start this kind of administration also in this period when that is a challenging period for which like patients often don't go to the hospital, don't go to see frequently a doctor and so let's don't delay the treatment.
So could you sum up in just 20 or 30 seconds what your findings are and what the brief recommendations are coming out of this then, a summary?
So I think, as I said, that now we have evidence, like based on this epidemiological study, that patients affected by prostate cancer in ADT are protected. So now these should be used by infectiviologists and other clinicians to run prospective clinical trial. And I hope that this could be of some useful for this colleague of mine. I'm again a cancer doctor, so I'm an oncologist. So I really hope that infectiviologists so on will also try to validate this hypothesis.